Hello, everyone. Welcome to our Zoom meeting today. We will have the great team presenting for today's meeting. When you are ready, go ahead. Thank you so much.
Thank you. Hello, everyone. I hope you can hear me clearly. All right. So this is Rufaida, the Red Team leader. So today, our presentation is going to be presented by the Red Team. It's my first time to do this, actually. So bear with me. I hope everyone have enjoy our today's presentation. So to begin with, today we're going to be having the agenda of today's meeting is going to be nutrition and weight changes in older patients, which is going to be presented by Dr. Sulafa and Dr. Esar. And then we have pain management in older adults. It's going to be presented by Dr. Amna. And then we have the third one. It's the annual geriatric meetings on other specialties, which is going to be presented by Dr. Hoyam. And then you're going to be having me presenting the e-prognostic application, how to use it. And then the last thing, we're going to be ending with the project updates. So if Dr. Esar and Dr. Salwa are ready to present the first agenda, you can start now.
Hello everyone, yes, I'm ready. Assalamu alaikum, Eidkum Mubarak inshallah. My name is Dr. Esar. I'll be presenting nutritional and weight changes in elderly. Just give me a few moments to share my screen. Do you see my screen?
Yes.
Okay,
yes.
And you hear me clearly?
Yes, it's all clear.
Yes.
Okay, so starting, we'll talk about nutrition and weight changes in elderly. By the end of this session, we'll be able to describe the age-related changes in nutritional health. We'll know how to screen and assess for nutritional deficit in an elderly. We'll talk about nutritional syndromes in elderly adults and how to intervene with them. We'll also talk about cultural factors, legal and ethical issues related to nutrition. Starting with age-related nutritional changes, we'll talk about the body composition, energy requirements, macro and micronutrients need in an elderly, and the fluid needs. We'll start with the body composition. We all know that the body composition changes with age. There is a decrease in bone mass, lean mass, and water content, and increase in total body fat, especially intra-abdominal fat stores. Because of these changes, there will be a change in distribution of many medications. Because of the decrease in lean mass, there will be an overestimation of renal clearance in our elderly. We cannot generalize the nutritional requirements in young or middle-aged adults to the older adults because of these changes. Talking about energy requirements, there's going to be a reduced basal metabolic rate, and this is because of the decrease in lean body mass. The basal metabolic rate will determine the total energy needed per person. The estimated need 25 to 30 per kilocalorie per kg per day. Because of this decrease in body mass lead and the basal metabolic requirement, we should avoid overfeeding in an elderly. The United States Department of Agriculture, they modified the food pyramid according to age. This is a website, choosemyplate.gov. We can check it and see the modified replacement. Okay, now we'll move on to talk about macronutrients and micronutrients. Okay, the Food and Nutrition Board, Institution of Medicine, and the National Academics, they recommend a prudent diet, which consists of 0.8 gram per kg per day of protein. And for individual under stress, it's going to be 1.5 gram per kg per day. A fat of 20 to 30% of total energy, and this should be consistent of low cholesterol, low saturated fat, and trans fat acid. A carbohydrate, which is a complex carbohydrate, 45 to 65% of total energy intake, and a fiber of 30 gram per day in men, 21 gram per day in women. Okay, the recommended dietary allowance, which is the daily nutrient intake that will allow a healthy individual to meet the daily requirements of 97 to 98% per day. There is a specific website we can check for these guidelines to know the daily recommended allowance. Okay, the fluid needs of an elderly with aging, there is a decrease in perception of thirst, there is an impaired response to serum osmolarity, and a reduced ability to concentrate urine. According to this, the average elder adult will need 30 ml per kg per day. There is also another causes of decreased fluid intake, could be resulted from disease status that reduce mental or physical ability to recognize or express thirst. We should keep an eye on signs of dehydration. We all know decreased urine output, constipation, mucosal dryness, and confusion. Okay, now we'll move on to talk about nutritional screening and assessment. How to assess an elderly for a nutritional deficit. We should do anthropometric measurements. We will assess his nutritional intake, do some lab tests, drug-nutrient interactions. There is a multi-item tool for nutritional screening. We'll talk about this later. Starting with the anthropometric measurements, they are used to assess nutritional status in elderly, as we mentioned. It mainly includes the BMI. A BMI less than 18.5 is a threshold of a low BMI. Unintended weight loss of 10 pounds in 6 months is an indicator of a morbidity. This will predict functional limitation, healthcare issues, and a need for a hospitalization. The MDS-3 consider weight loss of 5% in 1 month and 10% in 6 months as a significant weight loss. Inadequate nutritional intake has been defined as an average intake of food or nutrients 25 to 50% below the threshold level of the reference dietary reference daily intake. We say that poor intake is often an indication of illness. Elderly who mainly reside in a nursing home residence are 5 to 18% of them. They do not meet the daily adequate nutritional intake. Problems with obtaining food can be limitation in resources, limitation in transportation and functionality, inability to prepare and consume food. Now we'll talk about how to assess nutritional deficit by lab test. Albumin is the first indicator. Hypoalbuminemia, although it lacks sensitivity and specificity, but it associated with It's an indicator for morbidity and mortality. Hypoalbuminemia associated with increased lengths of stay, complications of readmission, and mortality in the hospital setting. The prognostic value of low albumin less than 3.8 is used as a marker for injury, disease, or inflammation. Pre-albumin can be used also as indicator. In short, maybe excuse me, pre-albumin may better reflect short-term changes in protein status, but has largely the same limitation as albumin because of the shorter half-life of pre-albumin. Cholesterol, serum cholesterol can be used as an indicator too. Low cholesterol less than 160 mg per deciliter detect an individual with serious underlying malignancy. An acquired hypocholesterolemia is a non-specific feature of poor health status that is independent of nutrient and energy intake. It may reflect a pro-inflammatory condition. Using low albumin and low cholesterol together, they have a higher rates of morbidity and mortality than those with either a low albumin or a low cholesterol. So we'll use low albumin and low cholesterol as an indicator, both together. We'll talk about drug-nutrient interaction. Medication can modify the nutrient needs and metabolism of older adults. There are certain medications, such as digoxin, phenytoin, can cause anorexia in older adults. Many medications are not known to interfere with taste and smell, and others can reduce the availability of specific nutrients. Some medication can cause inattention, dysphagia, dysgeusia, or xerostomia. Medication that cause constipation will also reduce appetite and will affect the nutritional status of an elderly. This is a list of drugs and how they affect the availability of nutrients. We have here alcohol, antacid, antibiotics, colchicine, digoxin, diuretics, isoniazid, laxative, levodopa, lipid-binding resins, metformin, mineral oil, phenytoin, salicylates, SSRIs, thiophyllenes, trimisoprines. They all reduce nutrients availability. There are multi-item tools for nutritional screening. The nutritional screening initiatives, there are 3 interdisciplinary tools to screen for nutritional risk and help to evaluate the nutritional status of elderly. Number 1, determine checklist. It's a self-reported questionnaire, consists of 10 items. It identifies population or people with a risk of malnutrition, but it does not diagnose malnutrition. It composed of 2 levels, level 1 screen and level 2 screen, and they are both used by certain healthcare professionals. The second is mini nutritional assessment. It consists of 18 items. It requires administration by a trained professional. It evaluates the risk of malnutrition among frail older adults and identify who may benefit from early intervention. It is available as an app for phone and tablets. The third is a simplified nutritional assessment questionnaire. It can be answered by patient, either through mail or while sitting in a waiting room. The sensitivity is 88.2, specificity 38.5% for identifying the risk of weight loss. I'll talk now about the risk factors for poor nutritional status: alcohol or substance abuse, cognitive dysfunction, decreased exercise, depression and poor mental health, functional limitation, limited mobility and transportation, inadequate funds, limited education, medical problems, chronic disease, medications, poor dentition, restricted diet and poor eating habits, and social isolations. All of those are risk factors that will affect the nutrition and will lead to a poor nutritional status in an elderly. I completed my portion of the presentation. I will now leave the stage for Salwa to carry on.
Hello, everyone. My name is Dr. Salwa Gasmalseed. Thank you, Dr. Esar, for this informative presentation. Thank you, Dr. Nader, for giving us this opportunity to prove and improve ourselves. And thank you, everyone, for being here. Just give me a second to share my screen. Do you see the screen now?
Yes.
Yes.
Okay. I would like to start by talking about the nutritional syndromes. We'll start with the involuntary weight loss. So what is considered as under involuntary weight loss is the weight loss of 10 pounds, which is 4.5 kg, or more than 5% of usual body weight over a period of 6 to 12 months. A BMI less than 17 is consistent with undernutrition, and excess loss of lean body mass is associated with poor wound healing, infections, pressure sores, depressed functional ability, and mortality. Involuntary weight loss. Let's talk about the prevalence. It's present in approximately 13% of older outpatients, 25 to 50% of hospitalized older adults, and more than 50% of nursing home residents. Talking about the causes of involuntary weight loss, approximately 50% are organ-related. They may be related to congestive heart failure, chronic obstructive pulmonary disease, renal failure, chronic infection, inflammatory states, GI conditions, or it could be adverse effects of the medication and neurodegenerative condition. Lower percentage, about 20%, each is related to neoplastic causes and idiopathic causes, and 10% is psychological conditions. So how do we evaluate for the inappropriate weight or involuntary weight loss? We start by doing careful documentation of weight over time. So it's important to take the weight of the patient at each visit. After that, we have to do a detailed history, including medical history, dietary history, psychological elements, because all of these can affect the nutrition of the patient. Thorough examination of the patient, looking for, as Dr. Esar said, signs of dehydration, of wasting, like this. Focus additional testing may be necessary. That is based on the history, physical, and limited standard lab profile. An institution of treatment of underlying cause, if any. Appropriate follow-up to assess response to the management. Okay, nutritional therapy. Nutritional therapy should include dietary education, removing dietary restrictions for chronic conditions, nutritional supplements given between meals, and multivitamins, multi-mineral supplementation. The second topic is obesity. Obesity is defined as a BMI of 30 kilogram per meter square or more. It is associated with many health problems like hypertension, diabetes. It increases definitely the cardiovascular risk, obstructive sleep apnea, and osteoarthritis. Adverse outcomes include impaired functional status, increased healthcare resource use, and increased mortality among elderly patients. Prevalence of obesity has increased in all age groups, in both genders, and all racial and ethnic groups. So nowadays, obesity is worldwide problem. Treatment of obesity. Our goal is to achieve a more healthful weight to promote improved health, function, and quality of life. So this is the goal. How do we achieve this goal? We use a combination of prudent diet, which is a diet that have a high portion of protein and low portion of fat and cholesterol contents. Behavioral modification, and also we have to support this with a physical activity. An important point here for frail, obese, older patients. We emphasize preservation of strength and flexibility rather than the weight reduction. So our goal is the overall health of the patient. From the National Institute of Health, age alone should not preclude weight loss treatment for older adults. A careful evaluation of potential risk and benefit in the individual patient should guide the management. So now we're going to talk about the oral nutrition. Okay. Preventing undernutrition is much easier than treating it. Okay, so how can we enhance the food intake? Because prevention is better than cure, as we know. Catering to food preference as much as possible. Avoid therapeutic diets unless their clinical value is certain. Placing 2 or more patients together has been proved to increase sociability and food intake. Preparing food with appropriate consistency, appropriate attention to color, texture, temperature, and arrangement. Also using of herbs, spices, and hot foods, it helps to compensate for loss of the sense, which is one of the aging process. You know, as people get older, there is a gradual loss of the sense of taste, there is gradual loss of the saliva. So we overcome this by adding the herbs, spices, and hot food to overcome the loss of taste and smell and avoiding the excessive use of salt and sugar. Also, we have to avoid hard to open individual packages and give an adequate time for leisurely meals. Nutritional supplements. Nutritional supplements, they often decrease food intake, but overall nutritional intake increases. Why? For due to nutrient quality and supplement density. The supplements contains macro and micronutrients. It is available in liquid and bar forms. So how is it chosen? We choose it according to the patient preference, according to the chewing ability. As we said, there is a liquid forms and balm salt forms and product cost. Current evidence does not support routine supplementation. So it's not a routine for all elderly patients, does not support supplementation for homebound older people or well-nourished older patient in any setting. Use of micronutrient is growing. Approximately 60% of older adults, they take self-prescribed dietary supplement. Many vitamins and mineral supplements, they are commonly available in supermarkets and drugstores and generally safe, except for excessive intake of some of them, such as the lipid-soluble vitamin, because the body is not able to excrete them. They are stored in the body and they can cause toxicity symptoms such as vitamin A, vitamin D, and also the iron if are consumed excessively. There is poor to insufficient data that many nutrition supplements are beneficial. Take-home message. Imperative that the clinicians obtain information about the patient use of all supplements, because patients does not always mention this. So we have to ask the patient about the use of the supplements. Finally, we're going to talk about the vitamin D deficiency, which occurs in about 30% of individuals more than 70 years old, which is not something that we can overlook, associated with impaired calcium absorption, reduced physical activity level. The United States Preventive Services Task Force said that insufficient evidence to screen for vitamin D deficiency in asymptomatic adult. So it's appropriate to screen for vitamin D deficiency for older patients at risk for deficiency, such as the patients that have weight loss or if they have malnutrition. Current recommendation for all older adults include a daily intake of calcium of 1 gram and vitamin D of 10 microgram just to prevent osteoporosis. So this is preventive dose. It cannot cause toxicity. Undernutrition syndrome, drug treatment. There is no report demonstrating improvement in long-term survival. The drug treatment may even cause serious adverse effects, so we have to be cautious. The adverse effects associated with commonly used medication for weight loss are Mirtazapine, we have to be cautious with doses more than 15 milligrams per deciliter due to hepatic and renal insufficiency. Cyproheptadine can cause confusion. Megestrol, which is a progesterone, synthetic progesterone. It's on the peers list, the drugs that we have to be cautious when giving it to elderly patient. Why for? Megestrone increases the risk of DVT, fluid retention, edema. It also can exacerbate congestive heart failure in susceptible individuals. It may negate effects of exercise and strength function. Doronabinol, which is a cannabinoid, it can cause somnolence and dysphoria. Human growth hormone is contraindicated in carcinal patients because it will increase the proliferation of the cancerous cells, which is something we don't want, and hyperglycemia because we know it have an anti-insulin effect and fluid retention. In anabolic steroids, they have no significant improvement in strength, function, or reduction in fractures. Culturally appropriate nutritional care. We have to know that ethnic and religious customs are two of many factors that influence food preference. Nutrition and aging are connected inseparably because eating problems affect progress of many chronic and degenerative disease associated with aging. Culturally appropriate nutrition education material are found below. You can check them. The final part of our discussion today is legal and ethical issues. Food and fluid should always be offered to all patients. Decision to start or to discontinue artificial nutrition or hydration, it must be considered very carefully. Competent adults may choose to forego artificial feeding according to the autonomy of the patients, just as they have the right to decline any invasive procedures. Okay. Advance directives should be honored unless there is a compelling evidence that the individual would have changed his or her mind in the current. Incompetent adult without advance directives. The decision to start or to discontinue artificial feeding should be considered carefully with a surrogate. Take into account three things: risk and burden of such an action, risk and burden of alternative actions, and evidence of to support the likely benefit of the various actions. Current evidence does not support the use of feeding tube in patients with end-stage cancer, patients with dementia, or patients with chronic obstructive pulmonary disease. Palliative care, including emotional support, is extremely important at the end of life. So in a nutshell, the nutritional concerns affect many aspects of health and disease in older patients. There is acceptable parameter of nutritional status, such as body weight and protein level should be maintained unless the patient's clinical condition demonstrates it is not possible. There are many tools to help screen and assess for nutritional deficiencies. Cultural factors plays a role in nutritional intake. The decision to start or discontinue artificial nutrition or dehydration must be considered very carefully. So we finish. We have some cases here. Welcome for your participation. 88-year-old man comes to the clinic because of unintentional weight loss over the last year. He has lived alone since his wife's death 12 years ago. He's accompanied by his son. His son has managed his finance for the past 12 years. The patient is otherwise independent and continues to drive himself to local stores. The son says that his father is less active socially than the past and spends most of his time watching TV. The patient says that he eats and sleeps well, has no depressive symptoms, weakness, or dizziness, and has had no change in bowel habits. He has no surgery or serious illness in the last 10 years, and he takes no medicines regularly. Colonoscopy done 2 years ago to evaluate minor hematochezia, and it was normal. On examination, his weight is 73, down 14% down than 1 year ago. His BMI is 23, which is normal. Remainder of examination findings are normal. Fecal guaiac test is negative for blood. Score on mini mental status examination is 28, and Patient health questionnaire score is 0. Lab finding, he has normal urinalysis, CBC, electrolytes, normal liver, kidney, and thyroid function, normal chest radiographs, and normal sinus rhythm on EKG. Which one of the following? Diagnostic evaluation is now indicated. So you can put your answers. So the answers are passing between A and C, and the correct answer is no further testing. 81-year-old woman was admitted to the hospital 3 days ago because of hypertension, depressed sensorium, and urosepsis. 5 weeks earlier, she had perforated gastric ulcer and sepsis. Her post-operative course necessitated prolonged stay in the hospital and nursing facility. In the current hospital stay, she responded to IV fluids, antibiotic, and she is now alert and cooperative. For the last 2 days, she has been on a regular diet with polymeric oral nutrition supplements between meals. Nurses noted that her nutrient consumption ranges from 25 to 75% of meals. On examination, her weight is 64, down from 69 3 months ago. Her BMI is 21.6. There is non-inflamed surgical wound. There is 4+ pre-tibial thigh and pre-sacral edema. Her serum albumin is low, 2.7 grams per deciliter. Our question is, which one of the following is the best option at this point to determine the patient's need for additional support? So the answer is C. We have to order calorie count for 3 days to assess for her weight loss. Okay, and to make sure she's having enough calories. 69-year-old man is transferred to the medical unit after spending 6 weeks in the ICU for ventilator support related to post-influenza pneumonia and acute respiratory failure. A big tube was placed 4 days before transfer to the medical unit. The patient was started on polymeric feeding solution at full strength. The rate was 70 ml per hour, but the feeding rate has not been increased beyond 25 ml per hour because of development of multiple liquid stools daily. Despite efforts to identify cause of this patient anorexia, his volitional nutrient intake remains near 0. So we have a problem here. He has no history of Clostridium difficile. There were no cases of Clostridium in the ICU or his hospital ward in the last 2 weeks. He has had no nausea or vomiting, abdominal pain or cramping or tenesmus. He's not taken medications that contribute to diarrhea, and contaminated formula has been excluded. Before hospitalization, his weight was 72. His BMI was 23. On examination, he is alert oriented, his temperature is normal, his weight is 64. There are scattered rhonchi and wheezes in both lung fields, but no crackles. JVB is normal, heart sounds, abdominal examination, everything is normal. Fecal ocal blood is negative. Functioning back tube is in place, and feeding are being delivered at 25 ml per hour. His lab finding, albumin is low, 3.1, pre-albumin, serum sodium, BUN, creatinine, phosphate, white blood cell is normal, but his hemoglobin is low, 10.4. So he's having low albumin and low hemoglobin. Which one of the following should be done next to improve this patient nutritional status? You are correct, Dr. Fatima. It is prescribed loperamide. Because of the diarrhea, the patient will not get any benefit from the calories he's taken through the back tube. Thank you, everyone, for being here. Do you have any questions? I hope this was useful for you.
Thank you, Dr. Salwa and Dr. Esar, for the very informative presentation. If any of you have a question, you are free to ask before moving to the next agenda.
You are welcome.
All right. Since no one have a question, then we can move to our next presentation, which is pain management in older adults. It will be presented by Dr. Sulafa.
Assalamu alaikum, everyone. I'm going to present pain management in older adults. Are you able to see my screen?
Yes, it's very clear.
Okay. Pain definition. Pain is a complex, unpleasant phenomena composed of sensory experiences that include time, space, intensity, emotion, cognition, and motivations. Pain is an unpleasant or emotional experience originating in real or potential damaged tissue. Pain is an unpleasant phenomenon that uniquely experienced by each individual. It cannot be adequately defined, identified, or measured by an observer. Effective pain management. We should know the types of the pain, assess the patient level of pain, minimize pain with non-pharmacologic techniques, and then we're gonna add pharmacologic analgesia when needed, and avoid analgesics harmful to older adults, and anticipate and manage the side effects of opioid. We have pain intensity scales to estimate the severity of pain. It's either unidimensional scales like numeric rating scales, which is from 0, which means no pain, to 10 is the worst pain imaginable. Faces pain scale. Patient chooses a facial expression that corresponds to his pain or her pain. Verbal descriptor scale, no pain to pain as bad as it could be. And then we have multi-dimensional scales like McGill pain questionnaire and pain disability scale. Pain in cognitively impaired persons. Observe for the possible pain-related behaviors. Ask a caregiver for their observations. Consider trial of analgesia for the patient exhibiting pain-related behaviors. Validated scales like Hurley discomfort scale, checklist of nonverbal pain indicators require training. Provide empiric analgesia during procedures and conditions known to be painful. We have 3 types of pain syndromes. Nociceptive, it's pain due to activation of nociceptive sensory receptors, often adequately treated with common analgesics. It's either somatic or visceral. Somatic is well localized in the skin, soft tissue, bone, and the visceral is due to cardiac, GI, or lung injury. And the second type of the pain syndromes is neuropathic. It's from irritation of components of the CNS or peripheral nervous system, may respond well to non-opioid therapies, or responds unpredictably to opioid. The third type is mixed or unspecified, has characteristic of both nociceptive and neuropathic pain. It's common in older adults. Here are the types of pain, examples, and treatment. Nociceptive, somatic, like type of pain, an example, it's from arthritis, bone metastasis. The source of pain is a tissue injury to the bone, soft tissue, joints, muscles. The description is well localized, constant, aching, stabbing, gnawing, or throbbing pain. The effective drug classes and non-pharmacological treatments, we can use acetaminophen, opioids, physical and cognitive behavioral therapies. The nociceptive, visceral, like renal colic, constipation, the source of pain is from the viscera, and the typical description is diffuse, poorly localized, referred to other sites, intermittent, paroxysmal, dull colicky, squeezing, deep cramping, often accompanied by nausea, vomiting, and diaphoresis. The treatment options is to treat the underlying cause and physical and cognitive behavioral therapies. The neuropathic pain, like cervical or lumbar radiculopathies, post-herpetic neuralgia, trigeminal neuralgia, diabetic neuropathy, post-stroke syndromes, herniated intervertebral disc. The source of pain is peripheral or CNS, and the description, it's prolonged, usually constant, but can have paroxysm, sharp burning, pricking, tingling, squeezing, associated with other sensory disturbances, like paresthesia and dysthesias, allodynia, hyperaglasia, and impaired motor function, atrophy, or abnormal deep tender reflexes. The effective drug classes and non-pharmacological treatments as TCA, anticonvulsant, SNRIs, antidepressant, opioid, topical anesthetics, and cognitive and behavioral therapies. For the undetermined pain, like myofascial pain syndrome, somatoform pain disorders, the source is poorly understood, and the description is no identifiable pathologic process or symptoms out of proportion to identifiable organic pathology. It's like widespread musculoskeletal pain, stiffness, and weakness. The treatment options are antidepressant, anti-anxiety agent, physical and cognitive behavioral, and psychosocial therapies. The non-pharmacologic therapies, depend on patient education and involvement in decisions, teach the patient to take medication properly, and how use assessment instruments. Provide partner-guided pain management training to caregivers. Cognitive behavioral therapies considered of non-pharmacological options, and the regular physical activity, like supervised rehabilitations for frail patients, or regular repositioning and gentle massage for the bedbound patients. And lastly, the referral to interdisciplinary pain clinics. The role of pharmacological therapies in controlling pain, besides pain relief, the goals are improved function and enhanced adherence to rehabilitations. Individualize the initial dose of the medication and rate of titrations. In general, start opioids at lowest dose and titrate slowly. But if the patient in pain crisis, do not withhold medication. So we need to increase the dose to treat the pain crisis. Try non-systematic or non-pharmacologic therapies first if appropriate. How we treat mild to moderate pain. The options are acetaminophen, non-steroidal anti-inflammatory drugs. Acetaminophen is particularly for musculoskeletal pain, with no use longer than the dose should not be greater than 4 grams every 24 hours. Lower the dose by 50% or avoid in patients are at risk of liver dysfunction, especially with history of heavy alcohol use. No all medication that the patient is taking, as acetaminophen is a common ingredient in prescription and OTC drugs. Non-steroidals has many significant adverse effects. Use COX-2 inhibitors with extreme caution, if at all, in older persons. Use judiciously, if at all, only after acetaminophen has been tried and only in high selected individuals. Treating moderate to severe pain. To estimate opioid requirements, conduct a trial of a short-acting opioid. Treat continuous pain with 24-hour opioid in long-acting or sustained release formulation. This to cover breakthrough pain combined with fast onset medication that have short half-lives. Breakthrough pain typically requires 5 to 15% of the daily dose, offered 2 hours orally. In general, different opioids are similarly efficacious. Cost and route of delivery can help guide the choice. Using opioids in renal failure to reduce the risk that the active metabolites of morphine will accumulate, increase the dosing interval, and reduce the dose. Hydromorphone is many experts' first choice for these populations because morphine has active metabolites. Safety of oxycodone in this population is still controversial. Combating fear of tolerance and addiction to opioids. Avoid withdrawal symptoms by tapering carefully over the days to weeks. If rapid upward titration is required to reduce pain, suggesting that tolerance has developed. Evaluate the cause of pain, include searching for new pathologies and exacerbation of a known source of pain. Consider non-physical causes of pain. So we should always pay attention for tolerance and dependence. There is limited cross-tolerance between opioids. When switching a patient from one opioid to another, reduce the dose by 50 to 65% of the equivalent dose. Manage the adverse effects of opioid. Adverse effects like constipation, nausea, and vomiting. For constipation, educate the patient about probable need for long-term laxative treatment. In most cases, start with stimulant laxatives, encourage exercise and hydration. Consider methyl naltrexone for the patient with opioid-induced constipation despite laxative therapy. For nausea and vomiting, evaluate for reversible causes. Then try a different opioid to treat with chronic antiemetics. For sedation, fatigues, mild cognitive impairment, educate the patient that these changes generally subside days to weeks after the dose adjustment. Warn against driving or operating heavy equipment when medication is initiated. Warn of the risk of falls. For incessant fatigue, try a stimulant such as low-dose methylphenidate or rotation to different opioid. For respiratory depression, use naloxone sparingly at the lowest dose and titrate carefully. Non-opioid medications like TCAs off-label are best studied drug for neuropathic pain. Optimal analgesia require treatment of depression. SSRIs are less well studied than TCAs as analgesics, but they are better tolerated in antidepressant doses. Duloxetine is approved as both antidepressant and for treatment of pain from diabetic neuropathy. Antiepileptics are commonly used for neuropathic pain. Corticosteroids are useful adjuvants for neuropathic pain and pain associated with swelling, inflammation, and tissue infiltration. Medications to avoid in older person is propoxyphene, mipridine, mixed agonist antagonists such as nalbuphine and butorphanol, and COX-2 inhibitors, and other non-steroids, and used rarely if ever. I think this was the last slide regarding pain management in older adults. Thank you so much for listening. And if you have any questions, feel free to ask. Thank you so much.
Thank you, Dr. Sulafa, for the nice presentation. If any one of you have questions, you're free to ask before going to the next agenda. All right. Since no one does have a question, then we can go to our next agenda, which is annual geriatric meetings and other specialties, which is going to be presented by Dr. Hoyam Bakri. Dr. Hoyam, the floor is yours.
Hello, Dr. Rufaida. Are you
Hello.
hearing me?
Yeah, your voice is clear.
Okay. So let me share my screen.
All right.
Just a sec. Hello, Dr. Rufaida.
Hello.
Do you see my screen? Is my screen shared yet?
Yeah, your screen is already shared.
Okay.
All right.
Okay, so hello everyone, this is Dr. Hoyam Bakri. I will be presenting the presentation regarding the annual geriatric conferences. First off, I would like to thank Dr. Nader for allowing this kind of opportunity. So let's start by talking about the annual geriatric conferences. Like we have conferences that or annual conferences that are held within the US, and then like we have other type of annual conferences that are held internationally. So first off, we are going to talk about the annual geriatric conferences that are held within the US. Unfortunately, most of these annual conferences took place earlier this year. So we'll start with the 2023 Annual Scientific Meeting of the American Geriatric Society, AGS, which took place in May 4th to 6th in the Long Beach, California. So here you have like the general information regarding the place where it took place and the time that it took place in. Here we have a brief information regarding the conference itself. So the AGS Annual Scientific Meeting is the premier educational event in geriatrics, providing the main information on clinical care. Just a second, let me take this.
Dr. Hoyam?
Yeah.
You're still on the view mode. Can you go to the presentation mode?
Actually, here I have it on presentation mode. I don't know what's wrong with it.
It's okay. You can just unshare and then
share.
Okay, I will unshare it and then share it. Okay. Is it shared yet?
Yes, it's perfect now.
It's perfect. Okay. So we'll continue. The AGS Annual Scientific Meeting is the premier educational event in geriatrics, providing the latest information on clinical care, research on aging, and innovative models of care delivery. The 2023 annual meeting actually addressed the educational needs of geriatric professionals from all disciplines: physicians, nurses, practitioners, pharmacists, physician assistants, social workers, long-term care and managed care providers, healthcare administrators, and others can update their knowledge and skills through the state-of-the-art educational session and research presentation. So this is a brief information regarding this conference that took place in California earlier this year. Okay, the second one we have is the American Association for Geriatric Psychiatry annual meeting, so known as the AAGP 2023. It took place in New Orleans, Los Angeles. It took place in the earlier this year. It was the specialties it covered was geriatric psychiatry. And here we have a brief information. It was talking about aging through a new lens, a focus on emergent strength, resilience, and diversity. Aging is typically defined by acute limitation and pathology, but it can equally be defined by emergent strength, such as wisdom, resilience, and creativity. This more positive take on aging is advanced by the diversity of experiences, contributions, and a peoplehood of aging individuals. In all circumstances, particularly amidst the mental health conditions that geriatric psychiatrists and other geriatric mental health clinicians see, the strength of aging emerge as key element of therapy and well-being. Dean Cohen described this positive process as creative aging and stressed that it came not in spite of aging, but because of it. So the 2023 annual meeting of the AAGP provided an informative, innovative, and inspirational forum to advance this critical message about aging. So it was mainly about aging. The second, or the third, actually, the third conference that we had this year was the 11th Alzheimer's and Parkinson's Drug Development Conference. It was held in San Francisco. It took place in 21st of February this year, earlier, and it talked about geriatrics and neurology. So the 11th Alzheimer's and Parkinson's Drug Development, it talked about mainly, first here, like they talked about the whole location and how it's really enjoyable. So, and then Parkinson Drug Development Summit is the only industry-focused event dedicated to overcoming the challenges and showcasing the opportunities of targeting Alzheimer's and Parkinson's disease, previously known as the Neurodegenerative Drug Development Summit. So don't miss your only opportunity to hear about the latest clinical pipeline progression in 2023, learn new insight into neurodegenerative disease mechanisms for a new target identification, explore the latest advances in neurological biomarkers and how to incorporate them into clinical trials successfully, and discover the next generation in vitro and in vivo preclinical models for safety and efficacy testing. Yeah, so it was a mixed geriatric neurology conference. And then we had, we had the American Association, American Association for Geriatric Psychiatry annual meeting. This one, actually, we talked about earlier, but is my screen shared in presentation mode?
Yes.
Okay. So we talked about this one earlier. It took place this year earlier, but we have the upcoming one in 2024. In the upcoming year, it will take place in Georgia, Atlanta. So it will take place in the 50th of May of the upcoming May, and up to the 80th of May in the next 2024 year. So the main specialty that it will cover the geriatrics, of course. The 2024 annual meeting theme in post-pandemic world calls for innovation that can reduce stress and trauma and promote brain health and well-being in millions of aging adults and caregivers in the United States and around the world. We will capitalize on transformative initiative in education, clinical practice, and research to promote brain health awareness among healthcare providers and the American families that lay the foundation of healthy and positive aging across all strata of our society and the world. The 2024 annual meeting will provide a stimulating forum and an opportunity to share our collective wisdom and passion for our profession. The annual meeting offers cutting-edge educational programming for a broad audience of allied health professionals, social workers, and researchers. We also encourage general psychiatry residents and medical students with a special interest in the mental health treatment of older adults to attend our annual meeting. Whether you work in a private hospital, clinic, state mental health facility, skilled nursing facility, or long-term care setting, or private practice, the AAGP annual meeting will have something to offer you. Attendee registration is set to open in October, the upcoming October in 2023. So yeah, they have the link. So this one did not take place yet. It will be in the upcoming 2024. Next, let's talk about the international annual conferences. So we had the 6th World Parkinson Congress, WPC 2023, which took place in Barcelona, Spain. It took place, it actually did not take place yet. So it's in the upcoming July, in the 4th of July, up to 7th of July. It's covering geriatric and neurology specialties. The 6th World Parkinson Congress will be held in Barcelona, Spain from July 4th to 7th, 2023. Everyone in the community who is touched by the Parkinson's, whether a researcher, physician, family member, clinician, nurse, or rehab specialist, is welcome to attend the WBC 2023. World Parkinson Congresses are 100% inclusive scientific events. So yeah, this one is yet to take place in the upcoming July. And then we have the Congress of the French Company and Palliative Care Society 2023. So this one actually took place in France. It took place in France earlier, 1 week ago, actually. Yeah, so it took place in the 14th of June, this June, until 16th of June. So it covered geriatrics, oncology, and public health and social medicine. So it took about, yeah, we will be happy to welcome you to Nantes. It's the city where it took place in, at the 29th SFAB Congress from June 14 to 16, 2023 to develop their test and savor meeting and dialogues. For more information, you can visit the link. Okay, and then next we have British Geriatric Society Spring Meetings 2023. This one took place in Edinburgh, Scotland. It took place in May, from the 70th of May to 90th of May. It covered geriatrics and internal medicine. The 2023 BGS Spring Meeting will be held as a hybrid conference with the option to attend in person in Edinburgh or to attend virtually. The meeting will cover the latest scientific researches and the best clinical practice in care of older people. This conference will cover core areas of interest to all specialists responsible for the health care of older people. Okay. So the next one we have is the Interdisciplinary Congress of Geriatric Professionals.
Excuse me, I'm sorry.
Yeah.
Hint, can you delete? Someone wrote on the screen, I think. So can you just undo it?
Okay.
Thank you.
I guess I can take it away.
All right, perfect.
All right, okay. Okay, so let's go back to presentation mode. Sorry about that, everyone. Okay, so we have the Interdisciplinary Congress of Geriatric Professionals. It took place in Montpellier. It was hybrid in France. So it took place in March, in 29th of March to 30th of March. It was covering geriatrics mainly. The 21st edition of CIPEG Congress will be held at the Quorum in Montpellier in France. This deadline will mark, we hope, the end of health crisis, which will have focused much attention on the elderly and highlighted the major role of players in geriatrics and gerontology, and more broadly still on the entire health system and professionals from health and medical social establishment and services. So yeah, this one took place in France earlier. And then we have the International Conference on Alzheimer's and Parkinson's disease and related neurological disorder, which took place in Sweden on March also. It was from 28th of March to, it took place to for the 1st of April. So it covered mainly geriatric neurology. So we invite you to join us at the upcoming Alzheimer's disease, Parkinson's disease 2023 International Conference on Alzheimer's and Parkinson's disease and related neurological disorders. The forthcoming meeting in 2023 will take place as hybrid conference in the vibrant city of Gothenburg, Sweden, and online. So it was hybrid. A high-quality scientific program covering most recent researches, developments, and treatments with emphasis on overlaps and congruent results among Alzheimer's disease, Parkinson's disease, and related neurological disorders. A multidisciplinary mix of participants representing both clinical investigator and basic scientists, as well as both established investigators and young upcoming talents. We invite you to join the Alzheimer's Parkinson's disease 2023 International Conference in 2023 in Gothenburg, or you could have attended online. So the next one we have is the it's the Behavioral Neurology Meetings, RNC, the 17th Behavioral Neurology Meetings. It took place in Paris, France. This was also a hybrid conference. It took place also in March. It took place from the 23rd of March to 24th. So it covered geriatric neurology and psychiatry. The behavioral neurology meeting, RNC, are a moment of exchange between professionals from various backgrounds, including neurology, psychology, neuroscience, psychiatry, and geriatrics, to address subjects at the border of all these disciplines. 2023 program, it had like, this is the link to the conference itself. Okay, and then we have the 51st Conversations of Physical Medicine and Rehabilitation, EMPR 2023. This also took place in Montpellier, France. It took place in the 22nd of March till the 24th of March. It covered general medicine, geriatrics, physical medicine and rehabilitation, rheumatology, surgery, occupational medicine. So it was held in Montpellier from March 22nd to 24th. Yeah, it was available in 14 specialized conference on physical rehabilitation medicine. And then like here, you have the link that you can access the whole thing there. Okay, and then we have the 25th National Conference of Dementias 2023. This one took place in Londres, UK. It took place in February, 9th of February to 10th of February. It was covering mainly geriatrics and neurology specialties. Dementia 2023 will be in London on the 9th and 10th of February 2023. So yeah, it was held in the past February. And then like we have the Healing Days 2023. So this also took place in January, actually, earlier this year. And then we have like a brief information about the healing days. It took like almost 2 months, 2 months from January till March. So the field of wounds has spread over the national territory without our authorities fully realizing the need for structuring, supervision, and here again, organization. Healing centers have flourished even in the smallest clinics because the financial return is certain. We have made progress on diploma courses, which are now mandatory to practice in the field, on certifications for doctors and nurses. There are still many fields in which this discipline has yet to assert itself. Surgeons are late, as well as most general practitioners, in the knowledge of prevention of chronic wounds. Patients are not yet sufficiently supported in the management of their chronic wounds. This GC 2023 Congress is an opportunity to review all these topics. It will be rich in basic training workshops in elementary care, will unveil the latest advances in artificial intelligence to help diagnose complexity, new therapeutic education, electronic education techniques, new devices, medicals, and electronic health, remote monitoring now being a possibility, including remote telecare. January will be the period of all possibilities. Yeah, it was, this had really interesting topic. And then we have the Geriatric meeting, the 2023. Yeah, this took place on the 60th of June, and it took place in Manchester, UK. So Geriatric meeting raised the awareness of the specific needs of older people with cancer, including multidisciplinary assessments and support during treatment. It is aimed at professions from all backgrounds with an interest in improving outcomes for older people with cancer. So yeah, this one took place already. And okay, so yeah, this is the same one. And then we came to an ending of this session with me. I hope you have enjoyed it, and I hope that this was a beneficial presentation. Thank you again, Dr. Nader, for this opportunity. And if anyone has any question, feel free to ask.
Thank you, Dr. Hoyam, for the very beneficial presentation. If anyone have questions, as she said, you're free to ask. There is a question in the chat that if you can summarize the ones that they're yet to take place.
Yeah, this is actually, okay. This is actually a very good question. Yeah, I wanted to do it already. So thank you for this person who asked the question. Okay, so we have only one actually that is yet to be held. It is an international conference. It's taking place in the upcoming July. Yeah, it's in Spain, Barcelona. It's the 6th World Parkinson Congress, WPC 2023. As I mentioned, it will take place in Barcelona, Spain. So it is in the upcoming July from 4th to 7th of July. And it will be covering, as the name implies, geriatric and neurology. So yeah, everyone in the community who is touched by Parkinson's disease can actually join this one. And then we have also, we have the annual geriatric meeting, I believe. It's in the next year, but this is not yet, this one. So the AAGS, it will take place in Georgia, Atlanta. It will take place in upcoming 2024, so next year. But actually, to be able to attend this conference, you need to register earlier, which is in October 2023, in the upcoming October. So yeah, this one was covering the it was the American Association for Geriatric Psychiatry annual meeting. Yeah, as I mentioned before, it will take place in Georgia, Atlanta, and it will be covering the post-pandemic world. Yeah, so I hope I answered your question.
Also, Dr. Osama is asking for the link, but she's going to be already sharing the slides.
Yeah, I will share the slides.
Yeah, so it already has the links.
Okay. It already has the links, exactly. Okay, is there any other question?
Excellent, excellent presentation so far, all of you presenters. Thank you so much. The conference is, thank you so much, Bian, for presenting all of them.
You're welcome, Dr. Nader. Thank you.
Yeah. So there are two ways of making use of these conferences. One of them is just to attend or participate as just learning opportunity for you to know about the subject or about the topics of interest for you, as well as making some connections. So if it's in person, then you go attend these meetings and you can make some connections with people there, either in the field or in the residency programs, for example. This is one opportunity or one way to take advantage of these conferences. The other way is to think about how we can participate in these conferences in format of either abstracts or posters, presentation or oral presentations. So our group here in the past few years participated in some of these conferences, and here's the list of some of them. So we participated in AGS, the Geriatric Society, and in 2021, and other conferences as listed here. So all this list is accessible on our publications website. These can be local, so some of them might be related to just university, for example, or programs in certain city or in certain areas like the mid-Michigan or mid-West internal medicine. This group is between like, it was in Chicago, I think, or Mississippi, but the states there included Illinois, Missouri, and so it's just part of the US. So it's a local conference. Some of them might be national. So you mentioned some of them in California, for example, or will be presented in Georgia. So all these conferences, you can look at their websites and see for the future for 2024 and see if they open the doors or the acceptance for the proposal for abstract submission. Some of them will open in July. Some of them might be in August or September. So the goal is to prepare a project that can target these conferences. And what you do is you look at what happened last year or this year during the conference, what topic they are interested in. You can look at their abstracts in the past that are presented and see how they cover some of the topics, and you can come up with some ideas. And if you are ready, you can prepare the abstract, and when they open the acceptance for the proposals, then you just submit your proposal. I suggest that when you planning to do that, when you're creating the team, one of the team members might be living near the area where the conference will be. So some of these conference, for example, will be, let's say, open in California. So you can ask one of the fellows who might be interested, who lives in California, to participate in the team. And then when you submit the abstract, if accepted, that person or that fellow will be able to attend the meeting. It's going to be less expensive for the group to go there, unless you are really interested and have some funding for the conference, things like that. So this one thing. The other thing is some of these conferences or association societies, they have memberships. So if you want, you can become a member of these societies or associations, and it will help you educate yourself about some of the topics of interest in this area. So they may have some education materials or some local chapters in your area. Let's say in Michigan, they have chapter for AGS or chapter for and some. So you can approach this and you can have opportunities for either volunteering or attending their meetings or making connections because some of them might be working in some programs, residency programs, for example. So if you make connections, you might have some opportunities for either externship or letter of recommendation. So there are other opportunities or other aspects of looking at this conference. Just I want to highlight how we can use or make use of this information. But thank you so much, Dr. Priyan, for sharing.
You
Thank
are
you so
very
much,
welcome,
Dr.
Nader, and thank you for sorry, Rufaidah. So
It's
thank you, Dr.
okay.
Nader, for the addition. This was really helpful, and I think this is a great way to make use of these conferences for real. Yeah.
Thank you, Dr. Nader, for the additive informations. Also, I may add, for those who are interested in neurology, there is the World Congress of Neurology that is usually take place every 2 years in a different country. There is an upcoming one that's going to be in Montreal, Canada. The registration is still open. For those who are planning to apply for the neurology match, it would be of a great additive for you. You can attend it either virtually or you can attend it on site. It will be taking place from the 15th to the 19th of October, upcoming October. What's unique about the World Congress of Neurology, it's the biggest neurology gathering. It's usually organized by the World Federation of Neurology. And within this conference, usually they open the abstracts, the open for the abstract submissions are usually around 8 to 9 months earlier. And what I know from my experience with them is that I've been attending this this is my third, it's going to be like my third year or my third time to attend it. So they have a very high acceptance rate for the abstracts. If you follow their guidelines, if you follow their topics, the list of topics, they have a very high acceptance rate. And usually most of the abstract that get accepted, it get published in the American Journal of Neuroscience, which is one of the biggest journals in the US and in neurology specifically. Inshallah, I'll be presenting 2 of my papers in the upcoming October. So if any of you guys need any information regarding the World Congress of Neurology, I'll be helping you guys. The other thing is also there is the European Academy of Neurology. Also, they have their conference that takes place also every 2 years. Also, it's one of the biggest neurology conferences. The upcoming one is going to be in the Budapest. It will be on July, but I'm not sure about the exact date. Also, I can share with you guys the links for both. Thank you. So the next part of our today's presentation is going to be presented by me. So I'll be talking to you about how to use the e-prognosis application. So let me just share my screen. Right. All right. Can you see my screen?
Yes.
Perfect. So regarding the e-prognosis app, like in simple word, the e-prognosis app is an application that has been developed to actually individualize prognosis, screening and everything, or to use prognosis and screening and everything in an individualized manner with regard to patients. So let's talk about it for a while. I cannot talk about the application without talking about the developers. The idea actually came from this person, Lindsay, who was a medical student at the UCSF, who thought that it's very important to consider prognosis with regard to patients in general. So they started to work on gathering data through a systematic review that was published at the JAMA on 2011. And then this systematic review mainly included, information regarding risk factors and how it could be used in a way that it could be help in providing prognostications with regard to patients. And then after that, they started to be thinking that maybe this is just on the, written on papers and it's not something very useful. So they thought about developing the application. As I said, the application mainly has three components. It's mainly the calculating the prognosis with regard to patients using a specific indices, and then the use of cancer screening also regarding using some indices, and then what's known at the time to benefit that I will talk about later. So let's start with prognostic calculators. My voice is still clear, is it?
Yes, it's clear.
All right. So regarding the prognosis, it asks you, it's mainly for physicians, this application. It would ask you about the settlement of your patient. Is your patient is living at home or in a nursing home or in hospital setting or in a hospice care. So based on your choice, let's go for, like, for example, let's say the patient is living at home, and then it would ask you, do you want to know about the mortality alone, or you want to know about the mortality along with the disability? So for example, let's click on this one. It would ask you, does your patient have dementia? Because demented people have, different parameters. So let's say no. And then is your patient in the United States? And then you can say it's either yes or no. So let's say yes. And then what time parameter best fits the clinical issues? Let's say if it's 1 year or 4 to 15 years, like it depends on what you want to know. If you want to know the prognostication for the upcoming year, or you want to know for more than 4 to 14 years. Is your patient is 65 years or older? Let's say yes. And then it would get you to this medical calculator. So when we get to this medical calculator, it would ask you about the exact age of your patient. Let's say it's from 50 to 60 to 59. And then it would also ask you about the sex, if it's a female or not. Let's say it's a female. And then later on, let's say the BMI is more than 24. So also it would give you other additional questions regarding does the patient have chronic lung disease? Does the patient has cancer, congestive heart failures, other comorbidities? Does the patient use a cigarette? And then you need to select if it's former smoker, current, or never smoker, for example. Does the patient has, because we, does the patient has difficulty in walking and everything, and then we already mark this as no, and then we can go to calculate the risk. So like any other medical calculator, it would give you the informations after calculate the risk. This one is actually the one that's for the patient that's not demented. It's called the Lee-Schomburg Index. Mainly it's used for community dwelling adults. Like the ones that living at home, age from 50 and older. Like geriatric patients. So all cause of 4, 5, 10, and 14 years mortality, and this is the outcome. And it would tell you to scroll to the bottom to see the individual risk. So the results based on the scores like we entered, the total Schomburg is 0. So your total Lee index is 0. So the risk calculator cannot predict further for any one individual. The risk calculator gives an estimate of how many people with a similar risk factor will live and die. So if you go to the points, it will tell you that the patient's risk of 10 years mortality, it ranges from 5 to 11. And the risk of 14 years mortality is from 19 to 21. So the patient have a 50% chance of death in a specific time interval has estimated life expectancy less than that time. For example, patient with a 60% mortality, risk at 5 years would be less than 5. All right. So in a simple way, this is the time, the benefit that we'll talk about later on. So in a simple way, we would just enter specific risk factors for the patients, and then the calculator would tell you the specific time interval that you want to calculate the mortality for that specific patient. Is it clear? Or if anyone at this point have a question, I would be like happy to answer. Hello?
Yes, it's
No,
clear.
it's clear.
Yes, it's clear. Go ahead.
All right, perfect. So this is regarding the medical calculator. There are others, like you can just, based on the patients, I mean, the individualized characteristic or the indices, then you can enter the information and then you can get prognosis about the specific patients. It doesn't have to be like mainly like patient with cancer. This is mainly estimate the overall life expectancy or the mortality or the disability for the specific patient, apart from any other conditions they have. Let's go to screening. When we come to screening, we know that certain patients actually do benefit from doing the screening because it would help in, mitigating whatever they have earlier at the early stage after detecting it. And other patients, they don't actually do have the risk to develop, for example, the breast cancer or the colorectal cancer or any type of the conditions. So doing the screening, it would only put more anxiety, and it would, also lead to overusing of the healthcare resources. So this application also helps you to individualize, like to whom do you need to screen and to whom do you need not to screen. And let's go, for example, to the colorectal cancer screening. It would ask you about the how old is your patient. Let's suppose the patient is, for example, is 50 to 59. And then it would ask you about the female. It would ask you about the gender, and then you can go for a female. And then it would ask you about the patient BMI. And then we can say it's above 25. And then there are other indices like, does the patient has chronic lung diseases, had cancer, congestive heart failure? Does the patient have difficulty in walking? And then all these other indices, and then you can calculate the risk. And then it would show you that the results into 3 categories. So mainly it will show you, it will show you the results actually in 2 categories, I'm sorry. So it will show you the benefits with regard to this patient. It will show you the harm with regard to this patients. So getting tested for colorectal cancer may lower the chances of the patient, for patients, for example. Getting tested is more likely to find colorectal cancer when it's small, improving patients' chance of only needing a minor surgery. Getting tested for colorectal cancer may help person feels good about his or her own health. And then with regard to harm, as I mentioned, it would also increase the amount of anxiety and the worry. Also getting tested may be uncomfortable. It may be also cause severe abdominal pain. I mean, like put the patient at side effects of the procedure itself. Occasionally, colonoscopy, a hole is incidentally made, as I said, and then also this is an adverse effect. In rare cases, testing for colorectal cancer may result even in death. So based on this calculator and based on the what's given, you can tell if this patient needs to be tested or not based on their risk and everything. All right. So the same thing goes for the breast cancer. And it will show you the exact risk of your patients. And at the same time, it will show you if your patient is going to be benefiting from this or not. There is also a second concept, or a third concept actually, which is the last one, which is the time to benefit. So based on the above things mentioned, I mean the colorectal cancer screening, and at the same time, the life expectancy and the mortality screening. Based on this information, you can tell what's the life expectancy of your patient. So some screening or some interventions, if done at a specific time period, it would be benefiting your patients. That's the time to benefits. And then if it's done in a specific time period, it wouldn't benefit the patients. And that's generally not recommended. So it's recommended that, for example, if your patient with a colorectal cancer have, for example, let's say has 9 years life expectancy, and then beyond this, if you did the test, it would usually benefit the patient because now you want to prolong their life, for example. This also not limited only to cancer, it include other stuff. It's not only for prolonging life, actually, it's also for, the general health condition of the patients. Mammography, for example, also, if it's done after, for example, let's say 11 years, and then this would benefit your patient. If the patient's calculated life expectancy is like 11 years. And then mammography after breast cancer, also, I think it's the same. So if you go to endocrine conditions, if you consider, like, for example, fenestride for the BPH, at the early time of the patient has a life expectancy that's short, for example, like 6 months, the patient won't benefit because, the fenestride needs time to take off, for example. And then if the life expectancy is more, then the patient most likely would, like, their symptoms would improve by using fenestride. Also, if you consider the bisphosphonate for osteoporosis prevention, for example, if the patient has a certain life expectancy, then they won't benefit. And then later on, this would benefit in preventing the pathological fracture, for example, by maintaining their bone age, but their bone density, I mean. Also, intensive glycemic control, for example, in patients, in order for us to prevent their having retinopathy or nephropathy or the microvascular complications. If the patient has a certain life expectancy, it needs a lot of time for that to occur. So giving patients, for example, like for 10 years, that would be very helpful. But it also, as I mentioned, it needs time to take off, or it needs time to, to show a preventive effect. So if they have, like, for example, 10 years life expectancy, that will be beneficial for them beyond this period. And the list goes on if you consider the intensive blood pressure control, also for the nephropathy and the retinopathy and everything. And then the statin for the primary preventions for the cardiovascular events, and hospice admission services, because patients with, this actually, when we come here, it kind of flips, because, like, for example, hospice patients, if their life expectancy is short, they would benefit from the, having their pain alleviated and everything. And if they have a longer life, expectancy, then they won't benefit, because, in order for you to be eligible to join hospice itself, you need to be having, you need to be dying within 6 months in order for you to be eligible. So it won't benefit patients with cancer conditions whom are having a life expectancy more than this. Also, there is the methylphenidate for depression. Also, when it's given early, it would help in the acute term. And then with the longer term, patient usually benefits from the SSRI. So in summary, this application was, the e-prognosis application was actually developed to help as a decision support application to help individualize each patient's prognosis, and at the same time, to whom should you be doing the screening and to whom you shouldn't be doing the screening. Thank you everyone for listening. And by now we are already, I'm done with my presentation. If any of you have questions, feel free to ask.
Thank you so much. is
Thank you.
excellent presentation. So as you saw, the initiator or the idea came from the medical students. So any one of you can bring an idea to the opportunities that people can help you develop similar tools or something useful for physicians or caregivers, sometimes for families as well.
Yeah.
So now it's easier to develop similar apps. Like the application development is not as difficult as in the past. Like you have to know how to code, and you need someone to write for you these codes and some technical support. I think it's going to become easier and easier if you have an idea and if you want to develop some user-friendly application. I think it's something that can be done. And some of you here in the group did develop different applications, and I think it will be useful to learn this and put it in your CV that you know how to, and hopefully if needed in the future, maybe you can develop one for your patients or for people in general. Thank you.
Thank you. Thank you, Dr. Nader. Now we go to the project updates. Everyone who has something to share, the floor is yours, free to share.
Any new ideas, any new projects? You can raise your hand with any comments or suggestions. Any new information about the application development? I know some of you developed some and some in the process. I know some of you also is going to present. I think one team is going to present in the Alzheimer Association meeting that will be in person and virtual in July. So congratulations.
Congratulations. Me and my team actually are working on the systematic review. We're almost done with that's the neurocognitive implications of COVID-19. We're almost done with the data collection, and we're hoping to write our manuscript within the upcoming days.
Excellent, excellent. Let me know if I can be of help. Excellent, good.
Thank you.
Go ahead,
Thank you.
Dr. Osama. Thank you.
Dr. Osama, the floor is yours. You can unmute yourself and then you can share with us.
Thank you. Hello, everyone. Yeah, I want to confirm what I mentioned last week on the meeting. I started my topic, I mean my study, but actually I need to know something. I don't know here if I'm like following the guidance or not. Yeah, as I discussed with you, Faida, I would like Dr. Nadir just to highlight if that's we are doing the correct thing. So I started like creating my own research team. So just to start work on the topic I used, I mentioned last week. Already I finished collecting the data, the articles we'll be working on. Maybe I'll start even writing maybe the abstract and the introduction. So my question is, how should we get, sorry for this background noise on the library. So I'd like to know how should we get the the mentorship and guidance while we are like doing these studies? Should we like be in direct contact with the team leaders, or how that work? This is my new project with this fellowship. So I would like to know the guidance, see how it works, so we don't do anything like. Am I clear? Do you hear me?
Yes, we do hear. I do hear you. Your voice is clear. Dr. Nadir, he's asking for your input.
So the mentorship, basically we use different methods. One of them is how we can help each other. So some of you have some experience as far as submission of abstracts, for example, presenting in conferences, and submission and for manuscript, for example, with journals. So you can reach out to those who already successfully presented or and their applications. So as I mentioned, the website here is the fellows who presented in the past. They have conferences, they have some other webinars, papers, abstracts. So you can reach seniors in this group as far as what you can do. Let's say you are interested in neurology, you want to submit to a neurology conference, then these fellows who were successful in presenting in these conferences, they can tell you, hey, this is how we did it. So for example, some of them just recently published some of these abstracts. And you can look at our videos in the past. Also, you can find the methods in the application if you look at our videos, how they present it. And usually we can work together to present in the group and then present in actual conferences if it's virtual, for example. The other way is to contact me, and then we can find some other mentor. I have Dr. Huff. He is a geriatrician here at MSU. He is willing to help with paper editing and publication. And we have a committee here at MSU Research Committee. They also helped some of you in the past when they have a manuscript. So they gave us a manuscript, we send it to them, they review it, and they give us feedback. We have Dr. Ahmed, also he is at my clinic in Minnesota, so he is also willing to help. We have collaborations with other mentors in other disciplines like cardiology, for example. In the past, some of the fellows worked with some cardiologists to present their work in some of the publications like posters. We are in communicating with one professor in UK who work also with some of the fellows finishing some paperwork. So there are different ways of getting advice or getting mentorship. It's just what you want to do and how you want to, what area, what's your topic, what you want to present, an abstract, where you want to send that abstract, or a paper where you want to send that paper, if that makes sense.
Okay, that makes a lot of sense. Thank you so much, Dr. Mohammed.
You're welcome. Thank you. Good question. Any other questions?
I would just like to add to your answer, Dr. Nadir. from personal experience, I think to Dr. Osama, things might not seem very clear at the beginning, but I really think if there are so many tools available in the Geriatric Research Fellowship app, and then the seniors can really help a lot. I have reached out to many of the seniors, and they have answered all the questions that you might have come across. And then so I just want to advise him that if you come together and form a team, things will get smoother as you go along. So just form your team, and then hopefully things will get clearer as you go ahead. Thank you.
Thank you, Dr.
Excellent. Thank you so much for adding that.
Thank you.
And remember, the goal is to know the basics of, let's say you are new to the research. We want you to know the basics of how to start the research from the idea, the research questions, all the way to completing the whole process. So each week we will touch base on some of these steps. You can look at our previous videos regarding these steps. Let's say you already know how to ask a question, you already know how to create the variables and collect the information, but you don't know how to analyze. So there are some videos about analysis of the data or how to use tools like SPSS or something. So you will focus on this area where you have the data, you want to work with it. So you look at some of these videos and work on improving that area. Then it's going to be the other parts of the steps, like as you mentioned, like if you have the whole things done, you want just to finish the abstract. So what I did in the past, as I was a resident, I looked at the previous abstract in the area where I wanted to submit. So it was the first conference or meeting that I presented. It was a case report. So I looked at case reports in the past, and I just not copy paste, but I took my material and format that in the same way others did in the past. When I presented it, some questions arise from that case, so I try to answer, and from that point going on, I work with when I become a senior resident, I work with my juniors on some other cases, same way. So we work as we go along. You learn, and to make sure whatever you learned is sticking, it's better to teach the other juniors. So in this program, for example, the seniors, they did the whole steps, as I mentioned, and some of them successfully submitted their work and accepted. So if you reach to them, they will help you whatever phase or point you are to go across to the next level. So basically, and the goal is, if you can finish one project during this period, you will be able to know the whole process hopefully, and you can start more than one during your residency or any in your future. Thank you. But the main point, as Dr. Mason mentioned, some of this might be difficult for one person, but if you work in a team, you can divide the task into small sections, and each one will handle one part, and it will be developed either faster or effectively. You will have more inputs from all these people or fellows. The second benefit of the team approach is that we are located in different time zones. So let's say I want to finish an abstract, submit it in the due date in a week. So I can work by myself, or I can divide it into some people, some division. Someone will be in California, someone will be in Saudi Arabia, in Michigan, someone in let's say Boston. So the one in California is the last one. We'll look at that. The one in Saudi Arabia, the first one, because of the time zone. So when they are awake, they can work on some of the parts, and then by the time I'm in Boston awake, I will work on my section. Then by the time California fellow is awake, they can work on the last part and then they can finish. So within 24 hours, we can finish it. Instead of myself, I would work on it on a week, for example. This is one benefit. The other benefit is that you already work on a piece, a part of the project, but you will get the benefit of the whole project. So when you work on part, you can work on different projects. So in your resume, you can list 3, 4, 5 projects you are working on. And if successfully submitted and accepted, in your resume, you will be listing 4 or 5 projects that published. Instead of you work by yourself in only one project the whole time, and it will be only one project completed. This is another benefit of team approach. So effectiveness, time management, and the list of projects under you. The first batch of this program, they worked together, they achieved, most of them, they published more than one project in their CV. One of them up to 7 publications and a webinar. So you can do as many, as I said. Thank you.
Thank you, Dr. Nadir, for all the informations and all the support. If anyone have further questions, you should feel free to ask.
Hi, Dr. Nadir. Hi, everyone.
Hello, Dr. Amal.
Hello, Amal.
Yeah, so I have a question regarding the applications that share patients' data. For example, in my case, our application share patients' data across different social media platforms like WhatsApp and Gmail. So I was wondering if privacy is an issue. So like, I'm scared that privacy is a limitation. Should we worry about this, especially that we are considering generalizability and the usability of our app, we are considering to spread our work. So I'm afraid that this is going to be a limitation.
I think it's a limitation, as you mentioned. So the way to figure it out, I think, is to look at similar or applications dealing with data patients, like private data, how they handle it. The other option is to make it called, basically you secure the data. So if you can, let's say, format the data and send it via fax, for example, secure method, that might be a better option. Here in the USA, the HIPAA regulations, so you can look at that and make it HIPAA compliant. So there are some steps to make it more secure for patients. In other countries, it might not be as strict. You can look at the regulation in different countries, for example. For applications that have education materials, you don't have to worry about that. But for this application, like the INR, when you want to get the whole data submitted via WhatsApp, I think you need to clarify the process to make it secure. I don't think WhatsApp is secured enough for clinical data or personal clinical data. If I answered you clearly.
Yeah, thank you so much, Dr. Nadir. Actually, I was thinking about making like a receiver app. Like the other part can access patients' data only through a password, like a receiver and a sender app. maybe this is going to work. I'm not sure. Instead of a social media platform.
That might be the other option. It's incorporated data from the patients, secure it, and send it to the receiver. The receiver get it and then open it. It's like a closed box or so. Yeah.
Yeah, thank you so much. So I have another question. So I'm done writing the proposal on effect of health mobile applications in reducing readmission rates among elderly population with chronic diseases. And may I submit it to you or send it to you for review prior to submitting to the website?
Yes, sure.
Thank you so much.
Yeah, no problem. Thank you. Good luck.
Thank you.
Any other ideas or questions? So for the next meeting, the blue team will be presenting some topics. Hopefully they will be able to. And if there's any questions, please let me know. I know it's gonna be Eid Mubarak in advance. Happy Eid, and we'll see you on the 1st of July.
Thank you everyone for the good listening. And as Dr. Nadir said, happy Eid for everyone. And thank you so much, Dr. Nadir, for everything.
Thank you so much, Dr. Rufaida and your team. Thank you all the presenters. This is excellent work, and I really appreciate your effort, your time. And thank you all attendees, and thanks for those who will come later. Thank you.
Thank you, Dr. Nadir.
You're welcome. Have a wonderful day, guys. Assalamu
You
alaikum.
too. You too. Assalamu alaikum.
Thank you so much, Dr. Nadir.
Thank you so much, Dr. Nadir.
Thank you.
Mubarak, Dr. Nadir, and everyone. Thank you so much, Dr. Nadir.
Thank you. You're welcome.
Thank you so much, Dr. Nader, and
Thank
happy Eid too.
Eid Mubarak.
Thank you so much, Dr. Nadir.
Thank you, Rahada.
Thank you, Dr. Nadir.
Thank you so much. Have a wonderful day. Eid Mubarak.
Thank you, Dr. Nadir, and Eid Mubarak for everyone.
Eid Mubarak.
Thank you, Dr.
Thank you,
Nadir,
Dr.
and Eid
Nadir.
Mubarak. See
Thank
you,
you.
everyone.
Can I say hi?
Yeah, you can say hi.
Thank you, Dr. Nadir.